Thank you everyone for attending the Health and Wellbeing Board held today on the Thursday 8th of July. This is my first meeting as the chair, so please do bear with me. It's my first meeting entirely actually. So point 1 of the agenda is membership and terms of reference. You can see there's a list of membership here. What I'm going to do to start with, because we've got some people who are clerking this for the first time and me chairing it for the first time, I'm going to ask for a roll call of names. So I'm going to start with this lady here, and I'll just move along and then move back, and we'll go from there.
Hi, good morning. Siobhan Brown, Chief Operating Officer at Northumberland Clinical Commissioning Group.
Thank you.
Jeff Watson, Cabinet Member for Healthy Lives.
Good morning, Glenn Sanderson, Leader of the Council.
Liz Morgan, Director of Public Health.
Ralph Firth, the VCS Assembly.
Thank you.
David Thompson, Health Watch Northumberland.
Morning, I'm Pam Travers. I'm the Group Director for CNTW for the North locality.
Good morning, I'm Wendy Paddison. I'm the Cabinet Member for Adult Wellbeing.
Ross Wigham, Deputy Director of Communications at Northumbria Healthcare.
Okay, I think I've got someone just arriving, just in time. Perhaps to introduce yourself.
Hello, it's Richard Hay, Head of Planning and Operations at Northumberland CCG.
That's right, I didn't recognise you in the flesh, seen you on the screen very many times. And of course, I'm Councillor Barry Flux, and I'm chairing this committee. I'm business chair normally, so this is my second big meeting of the week, or third big meeting of the week. So I'll go into the agenda. Point 2 is apologies for absence. Do we have any apologies for absence, Nicola?
Good morning, Chair. I have apologies from Gia Lothian, Jim Mackey, P. Mead, Kath McAvoy-Carr, Rick O'Farrell, Guy Renner-Thompson and Elizabeth Simpson. Thank you.
Okay, thank you very much for that. I'll go into minutes of the previous meeting, minutes of the meeting held on Thursday, the 11th of March. I'm noting there not a lot of councillors. I'm looking at you, Jeff. You was at that meeting. So I'm looking for anyone who was there to tell me that it was a true record. And
I think I was the only person there. I think I'm the only person here who was there that day. Oh, yes, they are.
okay, I think we'll second that if we're happy with that. A week is a long time.
You were there, Rob.
Are you okay to second those minutes for us?
Yes,
Thank you.
fine.
A week is a long time in politics, and for 4 months is a lifetime. So there we are. Next on the agenda is disclosure of interest. Do we have any interest to declare?
Excuse me, Chair, there's 2 sets of minutes.
I beg your pardon. Sorry, you're already ahead of me. I'm looking at the 8th of April as well to approve. Jeff, you were there again on the 8th.
Yeah, I'm happy to propose them as
Okay.
a true record.
Somebody who was there propose them as a second them as a true record. Yes, fine. Great. Thank you very much for that. Should be easier going forward with a new committee. And then disclosure of interest. Do we have any interest to declare? No. I shall go then and go into what I'm going to do. I think I'm going to do item 5, update on the Northumberland COVID outbreak prevention and control plan. I think that's Liz. I think Liz might be doing the item afterwards as well. Is that correct?
Yes, that's right.
That's
yes.
right. So what I'm proposing to do is do the presentations and then have questions after the presentations which take place.
Yeah, so this first item is about the local outbreak prevention and control plan. And I think what we will all recognise is that over the last year, we've had to face many challenges due to the pandemic and due to lockdown. And certainly the role of the local authority has changed significantly over that period in terms of controlling this pandemic. So we now have a central role around community testing, around outbreak management, around surveillance, enforcement, contact tracing and support to the vaccination programme. These are all areas of development that were not in place sort of 15 months ago. Now, the Health and Wellbeing Board has got a dual role as the COVID-19 Outbreak Control Board. And as that role, or in that role, the board's there to provide assurance that the plan is fit for purpose and that we're delivering that plan through the work of the Health Protection Board, which meets weekly. And it's also there to ensure that our internal incident response processes as an organisation are up and running as they should be. So this revised plan builds and updates on the key themes in the original plan, and it adds on additional plans and issues that have arisen since the last plan was published, which was June of last year. So in particular, this particular plan has got sections on how we respond to new variants of concern, around enhanced contact tracing, around the ongoing role of non-pharmaceutical interventions like social distancing, wearing of face coverings, etc., and our role in supporting vaccination. I think for me, over the last 12 months, the key areas of development have been the excellent cross-border outbreak control models that we've got in place. We've got really good management arrangements with our cross-border colleagues, demonstrated by the outbreak control meetings on Christmas Day that we had over that period, because of outbreaks on the other side of the border which affect our population. We've got a really effective local comms campaign, an award-winning comms campaign now actually, which is driven by local insight. We've developed a very comprehensive surveillance mechanism where we pull together data from all sorts of sources to get us a much better understanding about what is going on where and why. We've got our Northumberland local tracing partnership, and I have to say the customer care team in the local authority has been absolutely fantastic in taking on that task. And we've also taken on the responsibility for managing community outbreaks. So actually a lot of those functions that had traditionally been undertaken by our regional health protection team have, over a period of time, shifted across to the local authority. And I think the fact that we are able to manage outbreaks effectively is demonstrated by the very significant community outbreak that we had in the west of the county last year, which was brought to national attention, but the Joint Biosecurity Centre were assured that the measures that we had in place were appropriate and proportionate. And this new plan also includes an element around responding to variants of concern and what our plans would be for surge testing should that be required. Now, clearly, we're entering into another phase of the pandemic, and the approach is going to change radically after the 19th of July. So the contain framework, which is the framework which sets out how national, regional and local partners work with each other, the public, businesses, institutions and other system partners to prevent, manage and contain outbreaks, that will all have to be revised again, as will our plan. So this plan will survive contact until the 19th of July, and then we will need to revise it quite significantly to reflect the very different approach. But it was always meant to be iterative. It was always meant to be a plan which would have to be flexible and which would have to adapt to the direction of travel. So we will undoubtedly bring a revised version back to you in due course. So really the ask of the board is to just note the contents of the updated plan and our ongoing approach to the management of the pandemic. And if you've got any additional proposals for amendment, then very happy to receive those and make sure that they're included. And finally, we're asking the board to just endorse the contents as they are now, but recognising that it will need to be updated again over the next few weeks.
Okay, thank you for that. Did you want to move on to the next presentation, or do you want to take questions at that stage?
Perhaps we could take questions on this one, and then I'll move on to
Fine,
the actual
that's fine. Okay, so
update.
I'll invite, has anyone got any questions or points they'd like to raise on that? Jeff Watson.
Yeah, Liz, I wonder, it's probably a bit local question, but the policy that we've got as a council about people in cars, what will be, where are we with that? I mean, at the moment, I understand that we have this kind of rule that we have to have, if there's two people in a car, somebody has to be in the back with a mask on and the windows open, which means it negates the purpose of having two people in the car because they can't talk, which is what, what obviously we're trying to do if we're going a long distance. What will happen shortly? Are we changing it on the 19th or whenever?
So I think all of the measures that we've been adopting over the last 15 months have been absolutely critical in preventing transmission. My personal view is that moving forward, those sorts of interventions are still going to be really important in preventing transmission because, yes, we have got a very effective vaccination programme, but actually not everybody is vaccinated. Not everybody is vaccinated fully, certainly. So we still have got a lot of unvaccinated individuals who potentially form a pool in which new variants that could be more concerning than the ones we've got will be circulating. But I think, we have got to shift into a position where we are able to live with this virus because we can't continue to, operate as we are. We need the economy to open up for a number of reasons. So we need to take a measured and pragmatic approach. Now, I think as a local authority, we haven't decided what our approach is going to be after the 19th, but obviously under the health and safety legislation, we have got a responsibility to ensure that we keep our staff safe. So we need to think about how we apply those non-pharmaceutical interventions, so things like, good ventilation, the use of face coverings, hand washing, all of those things, as I've said, which prevent and still prevent infection. So how do we continue to put those into practice over the next few months? And I think, actually some of them will be really easy to continue to do. So, things like good respiratory hygiene, hand washing, actually, those are things that we can all do without them interfering with our daily lives at all, really. And I think those will be particularly important over the winter because, potentially we have got a perfect storm brewing of flu, COVID-19 and all the other respiratory viruses that we still need to prevent over the winter.
So, so do you think then we will review that? Because would it not be enough to have a rule where if you go with someone somewhere, that as long as you're wearing a mask in the same car, that you could go together? I'm thinking about some of the things that we have to do. Two of us are going to Hexham, for example, from here, and we're going in separate cars. If we go to Berwick, we have to go in separate cars. It's not good for anything. It's not good for being able to communicate. It's not good for use of fuel. I know it's obviously a good idea for COVID, but it's just getting a happy medium, I guess.
Yeah, and I think that is going to be the challenge, isn't it? Getting that happy medium. But I think there is a definite shift from having interventions which are laid down in legislation to having interventions which are based on personal responsibility and our own risk assessment of what we think is appropriate for that particular situation.
Thank you.
Yes, please, yeah.
Thank you. Liz, thank you very much for the presentation of a very comprehensive plan and an update about how it will be revised and so on. And whereas I realise the plan will be on COVID, will there be a link within it because of the prevalence of flu as the winter approaches, or will that be a separate document? Because there's a lot of talk about linking the flu vaccinations with the COVID vaccinations. So will you incorporate the two together, or will there be two separate plans, one for COVID and one for the potential flu outbreak?
So I don't think we were intending to produce a separate document, but obviously a lot of the principles that are in this plan will be effective for flu. But, you know, we are used to living with flu, you know, and managing seasonal flu is just part of our normal winter planning processes. But I think this year, clearly, we're going to need to think about the impact of respiratory infections, you know, in a much more comprehensive way, because we're anticipating actually the winter, you know, this winter could be potentially quite tricky.
Okay, thank you.
Anybody else? The leader, then.
Yeah, thank you. This is a good plan. I suppose my question really is what happens next in terms of preparing us for what could be a difficult autumn based on this. What are the plans for having a kind of a local inquiry is too strong a word, but a look at how we dealt with things and how we might improve things going forward. And then finally, and it's a political with a small p point, but I think one of the, for myself anyway, I became leader in September 2020, and this was one of the first first issue that sort of came into play. And it was very important for all leaders of the 7 authorities to be able to ditch any party political interests and work very closely together and show real leadership. And at times that leadership was very difficult because in parts of Northumberland, for example, there were very low cases or sometimes none. And some felt that we had gone over the top by working with partners in a wider area. For myself, it was really important that we worked together and took all the advice from public health experts. And I guess in a way, it's a bit of a shame that that's not mentioned anywhere in here at all. The fact that political leaders came together and did work together for the benefit of the community. So I do hope that that is picked up at some stage, because for me it was a real eye-opener and really helpful to be able to drop those political allegiances and work together. Thank you.
Okay. I don't know if there's anything Liz needs to respond to that there.
Well, I suppose only in terms of, you know, sort of reflecting on how well we've done. I mean, obviously there is a national inquiry, which is, I'm not quite sure whether it's actually started, but certainly I'm sure we'll be expected to feed into that. But I think you know, we would want, as a local authority, at a suitable point in time, I think you know, we'd want to look back on how we managed this pandemic and think about the things that went well and think about the things that, you know, that didn't go quite so well and where we could improve that, because that will inform our pandemic flu plan, which is sitting there in the background, waiting to be developed further.
Okay. Ralph, yes, I missed you there.
I just wonder, taking the point is that you were making about the changes after the 19th, whether the pressure then, perhaps in communications, would be about caring for others rather than protecting yourself. That that people might be more willing to stay with it, and if they saw it as caring for others, especially the many groups we've got in the charitable sector, you know, who are vulnerable and. To this. Yeah, I mean, I think there is a sort of, you know, general acknowledgement that getting the messages across after the 19th of July are going to be a bit of a challenge, because, you know, just because we can do something doesn't mean that we should be doing it. I think certainly you know, that local messaging is really important, and being able to tailor our communications to make sure that they resonate with our populations, I think is really important.
Okay, just 100% chat. I think we've done. I don't see anyone else with a hand up, so thank you for that one, Liz. And I'll go to the next item on the agenda, which is the COVID update, point 6. and we're just getting the screen back on. There we are. Fantastic.
Thank you very much. So there's a couple of presentations here for you. The first one is a sort of general update on where we are with sort of patterns of disease across the county, and then Richard is going to provide a separate presentation on vaccination. Or maybe not. Yeah, let's just do next slide, shall we?
Yeah. We did so well with technology at yesterday's meeting, and now it's...
That's because it's me. You see, I'm just the kiss of death on technology.
Here we are. There we go.
Okay. Great. Okay, so this is a chart which looks at positive test results by region over time, and what this is telling us is that cases are increasing in all regions. But unfortunately, the northeast is that yellow line, which you can see on the right-hand side is much higher than all of the other regions. So the northeast now has the highest rates in England and also the highest escalation of rates. So the rate of increase is higher than all of those other areas. So it wasn't really a field that we wanted to be heading, but that's where we are. From an LA7 perspective, it is those local authorities which in England certainly are heading up the sort of case rates. So I think we occupy 7 or 8 of the top 9 slots in terms of case rates. South Tyneside are out there at the front with rates which are approaching 1,000 per 100,000. Durham is down there at 604, and where the pale blue line just rubbing along at the bottom of that group at according to that chart at 400 and something. So really high rates. Certainly compared to where we were earlier in the year. Now, of course, those case rates really only identify the people who have been tested positive, and that's only really a tip of the iceberg, because we know that there are lots of people in the community, certainly up to half the people that are getting tested at the moment in Northumberland aren't experiencing any symptoms. So there are lots of people out there who have infection but who aren't being tested and don't get symptoms. And this ONS study looks at the prevalence of infection in the community. So it tests tens of thousands of people at regular intervals to see which ones come back with a positive test. And the most recent data, which was up until the end of June, suggests that the prevalence of infection has gone up just over a matter of a few weeks, from 1 in 520 to 1 in 260. So it's doubled in that period. Not unexpectedly, highest rates in younger people, particularly older teenagers and the younger working age population. Not much of an increase in age groups over the age of 70. And again, not unexpectedly, those estimates are highest in the northeast and the northwest. That's what the dashboard, our dashboard, is looking like today. So rates now are higher than they were at the peak in January. Roughly 60% of our cases are in under 30s, and about 1 in 9 of those PCR tests are coming back as positive. And you can see that there's a bit of geographical variation, but actually we have got cases across the whole of the county, although as usual not so many cases in our rural communities, because we've got lots of space and fresh air there, which is good for preventing transmission. From an age point of view, I think this really demonstrates how much infection we've got washing around our teenagers and that younger age population, particularly under the age of 24. You can see there that some of the rates are going up to 1,700 per 100,000. That's incredibly high in that age group. It's about 1 in 70. But equally, certainly if you're looking at the over 60s, there has been quite an increase, but it's much more modest, and we can attribute that to the vaccination programme. So what's the impact on schools and care homes and businesses? So from a care home point of view, actually relatively good news. So we have had an increase in cases in care homes, but actually it's largely in staff. We've got a couple of outbreaks, but it is generally just 1 or 2 cases in a number of care settings. So we're not seeing those massive outbreaks in care settings that we were seeing earlier in the year. Schools are under a huge amount of pressure. We're still seeing increasing cases in schools. So for the first 3 days of this year, we had 95, 61 and 70 cases referred to us in school settings. So that's causing a huge amount of disruption to children's education, but also to schools in terms of their resilience and their ability to continue to provide education, notwithstanding the fact that we have got large numbers of children, actually nearly 3,000 children and staff off school self-isolating because they're either close contacts or cases. But I think actually they're managing extremely well. And the fact that we've got those large numbers of cases in schools does not necessarily reflect transmission in school. It's what children are doing outside school, which is fueling those rates. And then I think it's the impact on businesses, which is really interesting. What our public protection team is finding is that they are getting increasing number of complaints about premises failing to apply controls, and a lot of that is related to football matches and hospitality venues. We're seeing an increase in workplace outbreaks, and again that just reflects community transmission. So the public protection team at the moment are managing 23 multiple outbreaks across workplace settings, and a number of workplaces which have got single cases. But actually what that means is that we're going to be increasingly focused on outbreak control and less focused on the sort of proactive work that we'd really like to do. I think this issue about workforce resilience is going to be quite significant. I think it's going to present a significant challenge across all businesses, whether they're the public sector or the private sector. We're finding that some of our hospitality venues are having to close because they just don't have the staff to stay open. And certainly, as an organisation, we're experiencing increasing absences relating to both cases, close contacts, and also parents who are having to stay at home to look after children. So I think obviously the important thing, or one of the important things, is what is the impact that this is having on the NHS. And I've got 2 charts here. One of them is looking at case rates or case numbers in Northumberland, and the bottom one is looking at hospital admissions over the same period of time. And if you look back at what we were experiencing in January, you can see that that peak in case rates and numbers of cases that we had in January was very quickly reflected in quite a significant increase in admissions to hospital. But when you look at what's happening now, even though we've got case rates which are actually higher than what we were seeing in January, we're not yet seeing that significant increase in admissions. And actually, despite the fact that our case rates are higher, admissions to hospital are only a tenth of what they were at the beginning of the year. We're also finding that the individuals who are being admitted are not as unwell, so they're spending less time in hospital. But actually, the Trust has reported a significant spike in the last 24 hours. So this is something that we really need to keep monitoring quite closely. I think looking at the experience of other areas which have had high rates of transmission for a longer period of time, so the Northwest, for instance, they haven't seen a sort of exponential increase in hospital admissions, so it hasn't reverted back to what they were seeing in January. So we're expecting that will be the case for us as well. But again, part of the pressure on the NHS is around staff absence, so they're experiencing exactly the same problem as us in terms of business resilience. And actually, I was at a meeting yesterday where they were reporting that nationally, 20% of NHS staff absence was attributable to COVID, whereas actually in the North East, it was up to a third. And I think that is going to be one of our challenges to manage. Step 4, obviously that was announced by the Prime Minister on Monday. So lots of expected changes, but I think the key one is this shift from having control measures enshrined in legislation to having control measures which are really guidance, and the government's leaving it to individuals to make informed choices about how they apply those preventive measures in their own circumstances. So all of those limits on weddings, funerals, sporting events, concerts, etc., they will all be lifted. Hospitality businesses will return or can return to function as they were before. Capacity caps are going to be lifted. And as I said, all of those non-pharmaceutical interventions around the 2 metre rule or the 1 metre plus rule, the limits on social contact, wearing of face coverings, etc., that will all be guidance rather than legislation. But what won't change is that symptomatic testing and contact tracing will continue, and it will still be a legal requirement to self-isolate at home if you test positive for COVID. We've also got revised proposals for the management of close contacts in schools. So the proposal is that from the 16th of August, if you've had your second vaccination, well, if you're 2 weeks post your second vaccination and you're identified as a close contact, then you won't need to self-isolate at home, and the same policy applies to anybody under the age of 18. And we're also seeing a significant change in how schools manage cases, and, well, not cases, but how they manage close contacts. So some guidance came out yesterday from the Department for Education, which we're just working our way through to understand what the implications are for schools going forward. But hopefully that will make it much more manageable for children to stay in more consistent education. There are a few gaps in the guidance, so we just need to work out how we're going to fill those gaps. Just another couple of things to focus on, the contact tracing and our local tracing partnership. I think, as I said before, our customer care team are doing an absolutely fantastic job having undertaken a task which was something they were really not familiar with at all. We are seeing increasing numbers being referred to us, so 388 cases in the week up to the 7th of July. And I think part of that increase is because the national team is also under pressure. So if they're unable to contact people within that 24-hour period, those cases are being referred to us as a local authority. So that's part of the reason why our cases are increasing for contact tracing. So in order to respond to that, we have put more capacity into the contact tracing team, but we're also prioritising the calls. So we're prioritising the calls to older people, to vulnerable groups, and to those cases in our more deprived communities. Also encouraging people to take a digital approach to responding to contact tracing rather than a phone call, which is obviously quite time consuming. We've also introduced a door knocking service. So obviously there are still some individuals who we aren't able to contact, and because we had actually had some concerns about the welfare of those individuals, we've now got a process in place where our COVID marshals actually knock on the door of those individuals just to make sure they are okay and to clarify that we've actually got the right details, and then they'll have a conversation with them about engaging with our local contact tracing team when they ring, and that's been really successful in getting through to people that we wouldn't otherwise have been able to contact. The other reasonably large area of activity is around asymptomatic testing, and that's largely now focused on the roving sort of community collect models. We still have one supervised testing facility up and running, which is in Ashington, but actually the take-up is very, very limited. So we're really focusing on this community model to encourage people to take up that testing offer. I think it's true to say that the asymptomatic testing programme is quite fragmented, so there are lots of different ways for people to access community testing or community testing to do at home. So they can do it through community pharmacies, through employers, they can order tests online. So lots of mechanisms for people to get themselves tested, but I'm not convinced that actually people are really signed up to that as a concept, and it's a continual challenge really to improve the take-up of asymptomatic testing. So I think the key messages really are that we've got rapidly escalating cases, and we are just about to lift restrictions further. So lifting restrictions doesn't mean that the risks from COVID have disappeared, far from it. The vaccination programme remains an absolute priority. That is the thing which is largely going to break that link between transmission and disease. And it's just really to emphasise that message again, that when people are offered the vaccine, please take up that offer, and also please go back and get your second vaccine, because actually the immunity that you have from 2 doses is much greater than the immunity that you would generate from 1 dose. And for those who have wanted to reflect on whether to have the vaccine or not, and to do a bit more digging over whether it's safe or not, the door is always open to those people who want to take up the vaccine. We need to continue to do whatever we can to prevent infection from washing through our unvaccinated and partially vaccinated communities, because that's how we're going to limit admissions to hospital, limit deaths, and also limit cases of long COVID. And I think we're becoming increasingly concerned and aware of long COVID as a syndrome. And as I've already said, we're also very conscious of the capacity of this unvaccinated or partially vaccinated population to generate a variant which is of more concern than the ones that we're already dealing with. And I think also the key message is about, you know, if we want to keep our businesses and the economy open, actually retaining some of these interventions, just the basic ones like hand washing, wearing a face covering if you're indoors with people that you don't normally mix with, ventilation, testing, isolating, all of those things will keep us going through the next few months. I'm not going to go through these in any detail, but we still have our 4 wraparound support groups which are supporting workplaces and businesses, education, care settings and vulnerable groups, and we'll send the presentation around later so that you can look at those in more detail. I think just from a comms update, we don't have anybody from the local authority comms here today, but I think this just gives you a flavour of the comms that we're doing as an organisation, and certainly we're targeting them in response to increasing case rates and also in response to outbreaks. So we're promoting the national campaigns, we're working with colleagues in the CCG to promote messages around vaccination and also about the use of NHS services, and we're working very closely with the Vaccination Hub to promote local messages around accessing the vaccination programme. The Beat COVID North East campaign has been really successful. It's recently won a public sector award at the Public Relations and Communications Association Awards for the North East, and we've got the 2 campaigns which are running at the moment are around improving vaccine confidence and around what we need to do to keep the North East open. And in terms of next steps, I think, you know, pretty much more of the same. The Chief Medical Officer talked about the importance of having a much more tailored approach to communicating with communities, and that's exactly what we're doing with this work. So I'm going to close there. I'm going to hand over to Richard, who's going to talk to you in a bit more detail about the vaccination programme.
Thank you, Liz. Can we get the slides up? Is there a clicker? Thank you. You can go on the next slide, please. Yes, so just to get the idea of the presentation today, give the board an update on the story so far with the vaccination programme, some metrics in terms of where we're up to in Northumberland and where we stand with our unvaccinated population that Liz has just been talking about, a little bit about next steps for the vaccination programme into the autumn and winter, and then just some reflections on the successes and challenges that we've faced since we started rolling out. So in terms of the sort of key headlines and the story so far, we vaccinated the first patient in the UK 7 months ago on the 8th of December. And on the 15th of December, we vaccinated our first Northumberland resident. We're now operating with 3 different types of vaccine across the programme. And as of yesterday, we had delivered 435,950 doses to Northumberland residents. There's been over 2,000 staff and volunteers involved in that effort. And our peak day in terms of delivering vaccinations was the 20th of March. When we delivered over 7,500 doses, so almost 3% of our population vaccinated in one day. We're currently sitting at 88.3% of our adult population who have had a first dose, and they've been vaccinated at one of 20 vaccination sites across Northumberland and 1 roving vaccination unit that we've got to ensure that nobody gets left behind by the programme. Next slide, please. So in terms of those vaccination sites in Northumberland, we've got 10 primary care network local vaccination services. They were stood up right at the start of the programme, and we got 10 sites stood up really quickly across the first 4 waves of sites that came online. We then brought online 8 community pharmacies more recently. There was a hospital hub operating at Wansbeck Hospital, operated by Northumbria Healthcare for predominantly health and social care staff to get vaccinated. We have opened for phase 2 of the vaccination programme a vaccination centre at Hexham Mart, and as I've mentioned, we've got the roving vaccination unit. There's been a couple of routes by which people can access their vaccine. So PCNs and hospital hubs operated local call and recall facilities, whereas the community pharmacy sites and vaccination centres utilise the national booking service, which I'll come back to later when we're reflecting on what's gone well and not so well on the programme. Next slide, please. In terms of the priority groups, so these were set out by the JCVI, and the vaccine programme has been split into 2 phases. So phase 1, which started back in December, was all of those over 50, those considered clinically extremely vulnerable, so cohort 4, and those in an at-risk group, who were cohort 6. So all of those patients were offered a first dose by the 15th of April. However, an evergreen offer does remain to those people, as Liz was just talking about. The latest data suggests we've got around 7,000 people in the county over 50 who've not received a first dose of the vaccination yet, and we would absolutely encourage them to come forward at any point to be vaccinated and get in touch with either their local healthcare provider or the National Booking Service. In terms of phase 2, that's still in progress. We've now been able to open up the offer of vaccination to everybody over 18, either via the National Booking Service or through our local sites. And the target is to, well, not just have offered everybody it, but we're operating to a target of delivering as many of those vaccines to those patients over 18 as we can by the 19th of July. Next slide, please. In terms of the vaccinations that we're using, cohorts 1 to 9 have been vaccinated in line with the JCVI guidance using one of 2 products, so Pfizer-BioNTech or Oxford-AstraZeneca. The Pfizer vaccine gave us lots of operational challenges early on in the programme. It's a very delicate product, and we only had 3.5 days to roll out batches once they'd come out of the deep freeze. So that was a real challenge for providers to get their heads around. And then we got the Oxford-AstraZeneca vaccine that came online, which is a lot more similar to the flu vaccine and a lot easier to roll out in terms of the logistics. We have, however, recently had some supplementary JCVI advice around the use of an alternative vaccine to Oxford-AstraZeneca for people in cohorts 10 to 12, so those under the age of 40, due to a potential risk of a very rare blood clotting condition. I think it's worth pointing out that risk does remain incredibly small and much less than the risk of clotting from other causes, such as smoking and particularly COVID-19. So we've used those Pfizer and Oxford-AstraZeneca vaccines across our PCN, community pharmacy and hospital hub sites. More recently, we've seen the Moderna vaccine come online in much smaller quantities, but that has been used at vaccination centres, and very recently, this week and next week, in fact, we're going to see some Moderna vaccines at our community pharmacy sites in Northumberland. And then there remain another 3 vaccines currently in development and going through a process of authorisation with the MHRA that could potentially be used further down the line in the vaccination programme, either this year or in future booster programmes. Next slide, please. So just to take you through some metrics in terms of how the vaccine programme's been delivered. In terms of first doses, that's the chart showing from when we started back in December to yesterday. In fact, this is the most recent chart. So you can see how quickly we mobilised and rolled out those first doses to our most vulnerable groups, cohorts 1 to 4, so that was everybody over 70 and the clinically extremely vulnerable. We then saw some supply challenges around early March. I think that was quite well publicised at the time, where the North East had done so well in the first wave of the rollout and then saw its supply restricted slightly so it could be evened out across the country. We then saw huge supplies towards the end of March and that record day that I mentioned on the 20th. Some supply challenges during April, again, that were quite well publicised, and we made sure we were prioritising second doses during that period. And then more recently, as we've moved into cohorts 10 to 12, we've seen an uptick in supply of vaccine that's been available for those patients, and we've been able to make some real progress there. Next slide, please. Just looking at the second doses alongside that, initially when we started the programme, the dosing interval was 3 weeks, so we were recalling patients who'd received their Pfizer vaccine 21 days later to receive their second dose. That didn't last particularly long in terms of guidance, and quite quickly there was a move from the JCVI and from government to delay the dosing interval to 12 weeks. That was quite controversial at the time, but what it did give us the opportunity to do was get a lot more first doses into people's arms and really increase that base level of immunity that one dose provides. So you can see there we had a large period where we didn't do any second doses as they were pushed back to 12 weeks. And then from the 1st of March, we really started second doses in a great number. And then more recently, we've seen second doses brought forward from 12 weeks to 8 weeks, initially for cohorts 1 to 9 in response to rising case rates. And then more recently, just in the last 5 or 6 days or so, we've seen advice now to bring forward all second doses to 8 weeks. But it's important to emphasise that's a minimum of 8 weeks. We don't want to, to go too quickly and put this vaccine into everybody's arms too quickly, because the data that we're seeing is that the best immune response comes when you leave it for a period of a minimum of 8 weeks. Next slide, please. Our vaccine uptake in Northumberland, I mentioned we were at 88.3% of our eligible population for first doses. That's the highest percentage uptake for first doses of any upper tier local authority in England. So we're absolutely leading the way on delivery of first doses, which is fantastic in terms of the amount of protection that gives our population. And on second doses, we're at 71.2%, so well ahead of the government's target of 66% of patients second dosed by the 19th of July. So our task now is to keep going and keep pushing beyond that 71.2% as we move towards the 19th of July. Next slide, please. Just looking at uptake across age bands, we've seen fantastic uptake in our oldest and most vulnerable residents. So we're at 95.5% for everybody over 50. And I think it's worth pointing out that we've also seen really strong uptake in our younger age groups as well. We're still vaccinating cohorts 10 to 12 alongside that evergreen offer. But we've seen uptake already in excess of 70% for those under the age of 25. Which is really good, actually, and testament to our young people coming forward and wanting to do their bit to protect themselves and others. Next slide, please. Looking at second doses alongside that, again, we're into the mid and high 90s for 90% uptake for our over 50 population. We have got a bit more work to do for those younger cohorts, but I think it's fair to say a lot of them have just been vaccinated with the first dose, so we're into their 8 weeks. And by the time we're through the summer, we should see really, really high uptake across the board, looking towards 90% of our population vaccinated with 2 doses in Northumberland, which would be a fantastic position to be in. Next slide, please. So just looking at the uptake and how it's increased, you can see there the progress we made with first doses in the first instance and how second doses is gradually catching that up. Next slide. Just looking specifically at some of our most vulnerable groups, I've talked about the high-level figures for Northumberland already, but in terms of our most vulnerable residents in care homes, the latest figures there suggest we've got very strong uptake in our care home populations. In excess of 96% of residents have had at least 1 dose and 95% have had at least 2 doses. And in the staff population in care homes, we're seeing figures in excess of 90% as well for first doses and in excess of 80% for second doses. And our teams in general practice are continuing to liaise with care home managers and staff to make sure we're continuing to offer that vaccination to staff for those who either haven't had it yet or those who need to get a second dose. Next slide, please. Across the wider social care staff, again, we're also showing very high vaccination rates across our social care staff. That's testament to the work that was done at Northumbria Healthcare and the hospital hub that they've got there. In excess of 90% of first doses across the 3 settings that are listed there, and second doses continue to be in progress for those teams. Next slide, please. Just to mention the work that's been done across multiple agencies to deliver the vaccination programme. This hasn't just been a primary care task or a hospital task, it's been a real cross-system task. So Northumbria Healthcare stood up a hospital hub at Wansbeck General Hospital, alongside another one they had at North Tyneside General, and delivered predominantly vaccinations to frontline health and social care workers and also any vulnerable inpatients that they had. We've seen brilliant multi-agency collaboration between the CCG, the Council, the System Vaccination Operations Centre, North East Commissioning Support and the Foundation Trust to identify and book staff into slots. You'd think that when that offer was made to frontline health and social care staff, they'd be fairly easy to identify, but there are a heck of a lot of frontline health and social care providers across lots of different agencies, and tracking them down and being able to give them a consistent route to book their vaccine was no mean feat. So the team did fantastically there to deliver over 33,000 doses from the hospital site in Northumbria, and the final mop-up clinics are taking place at the minute to do the last second doses for our frontline health and social care workers in Northumberland. Next slide, please. One of the things we were instructed to stand up by the National Vaccination Programme was a Vaccine Equity Board. So that was jointly established by the CCG and the Local Authority Public Health team. And we've used that board to identify and address potential areas of inequity within the vaccine rollout. Our priorities within that were Black, Asian and minority ethnic groups, especially our Black communities and Eastern European communities in Northumberland, Gypsy Roma traveller communities, those with a learning disability or serious mental illness, and we also looked particularly at socio-economic deprivation in Northumberland. As you'd imagine, in a county of our size and scale, rurality and travel time were also key considerations for us. And Liz has already mentioned the fantastic work that the regional comms groups have done to tackle vaccine hesitancy and try and increase vaccine confidence. And the Vaccine Equity Board has linked in with all of that work and made sure that we've tried to reduce any inequality in vaccine delivery. What we have seen recently, and with the rollout of the vaccine to younger age groups, is that we have got a little bit of inequity in delivery of first doses based on socioeconomic deprivation. So our most deprived communities have a much lower uptake of the vaccine, particularly in the youngest cohorts. So that's going to be a priority going forward to make sure we're targeting our efforts to increase that uptake as much as we can. Next slide, please. Just to quickly reference our roving vaccination unit, which is something we're incredibly proud of in Northumberland and has been a key part of the rollout. That's a unit that's led by one of our PCNs in Cramlington and Seaton Valley and was commissioned ostensibly to target our harder-to-reach groups and also to ensure we maintained local provision of vaccinations in West Northumberland, particularly during Phase 2 when the PCN there took the decision to opt out of delivery of Phase 2 so they could concentrate on routine general practice services. So we launched the vaccination unit in Bellingham in early April, and we've entered into a partnership with Northumberland Fire and Rescue to use their fire station sites across the county, predominantly in the west, to deliver lots of pop-up clinics. And we've also been to homeless shelters and independent residential settings, and it's enabled us to take the vaccine out to patients to make sure nobody gets left behind. We've also piloted with great success vaccinations within workplaces. So we've taken the van across to Egger in Hexham and to RPC in Haltwhistle and done workplace vaccination. I think that's a really innovative way of delivering the vaccine that will stand us in good stead going forward, looking at things like booster programmes and the flu programme. And we've also assisted beyond the boundaries of Northumberland. The van went into North Tyneside to assist with surge vaccinations when they were put on the watch list for rising cases of the Delta variant. And over the next 2 weeks, the van's going to be in Newcastle, particularly in the west end of Newcastle, delivering pop-up clinics to some of their most deprived communities to make sure that their uptake rate, which is a lot lower than ours in Northumberland, is maximised. Next slide, please. So the RVU got some really good national and local media attention, and it's something we've received a lot of inquiries about at the CCG, about how it works, what it can deliver, and it's a capability we're looking to maintain and enhance as we move forward through the vaccination programme. Next slide, please. Looking ahead then to Phase 3 and what comes next, we've just received in the last week or so some guidance on what to do during autumn and winter. So we've got some interim guidance on Phase 3 of the vaccination programme, and JCVI are advising that any potential booster programme should look to begin in September in order to maximise protection to our most vulnerable residents from serious COVID-19 as we move into the autumn and winter months. The initial advice at the minute is that booster programme should be offered across 2 stages. The first stage being all of those over 70, including our care homes, and all of those who are clinically extremely vulnerable, so cohort 4 from the first rollout, and all of our frontline health and social care workers. With the second stage being all of those over 50, and all of those aged between 16 and 49 who are in the traditional at-risk groups for the flu vaccine. So the core planning scenario is that we should look to deliver boosters of the COVID vaccine between the 6th of September and the 17th of December, so a 15-week period. And there are a number of clinical trials ongoing at the minute to determine whether the vaccine can be co-administered with the flu jab, so one in each arm at the same time, and what the best type of vaccine is to use. So we're awaiting final guidance from JCVI on what that's going to look like. I think it's fair to say that in the North East and North Cumbria, our ICS is very well placed in terms of our plans for the booster programme. We've got an ICS vaccination board that Liz and others sit on, and we've also got a really strong Northumberland vaccine collaborative that meets within our county, and we're already, as I say, well placed with the system planning. And what's going to be essential to the delivery of that booster programme is going to be a multi-agency collaborative approach, because of the other things we've got to contend with, rising COVID case rates, huge pressure on general practice, amongst other things. Next slide, please. So just a bit of reflection before we finish on why we've been so successful and what the challenges have been. I think we've seen across the board incredible engagement from a fantastic team of highly motivated and dedicated teams across all of our health and social care providers in Northumberland. Really strong coordination by the CCG with joint leadership across the CCG and the local authority. We've got a joint director post who's been leading the vaccination programme, which has enabled us to work really closely with Liz and her team and the teams across primary care. Our PCNs have collaborated fantastically across general practice and locality boundaries. PCNs are a relatively new thing and were very immature as organisations before COVID came along, and they've really been forced to work together in a really new and innovative way, and we've seen fantastic collaboration from our PCN teams across the county. I think we've had very strong system leadership, as we have up here in the North East in the health and social care sector, but our system vaccination operations centre that was stood up by Newcastle Hospitals has been very strong, and we've been able to build a great relationship with them, and that's enabled lots of pragmatic solutions to be taken when we've seen obstacles in the way of delivery. Liz has already mentioned the fantastic communication we've had with stakeholders and patients, and now award-winning communication, which is great to see. And as I've mentioned a couple of times, just fantastic integration and cooperation between all of the agencies that have been involved. Far too many to list on the slides there, but it's been fantastic to have everybody really pulling in the same direction and wanting the best outcome. And I think it's worth pointing out the public support we've seen for the vaccination programme, their confidence in us as providers, and their engagement with the vaccination programme has been brilliant. That's testament, I think, to the fact that we've got the highest uptake rates in the country for an upper tier local authority. Next slide, please. It's fair to say the vaccination programme hasn't been without significant challenge, and we've seen lots of things that have caused us frustration, caused us some sleepless nights, and numerous game changers, I think we've been referring to them as. So National Command and Control has left our local teams with all of the responsibility and none of the control over delivery of the vaccination programme, which has been very difficult for our teams on the ground. Several course corrections, that's those game changers I was talking about, and changes in guidance, often at incredibly short notice and more often than not in the media first before our providers actually found out. The unpredictable supply chain, which was always going to take place, I think, in a global vaccination effort, but that supply chain has worked around a push model, which is basically get what you're given, and those deliveries has made planning of workforce and how to plan those clinics to deliver the vaccine incredibly difficult. Lots of the nationally mandated decisions have not always reflected the need for local interpretation and flexibility. That's something very particular to us in Northumberland. Some of the decisions around, I think cohort 5 in particular, were instructed not to go to their PCN sites and go solely to big vaccination centres. At that point, we didn't have a vaccination centre in Northumberland because that wasn't the best model for us. So we had to go out with the nationally mandated decision there and be a bit more flexible. The multiple routes to access vaccinations have been confusing, I think, for patients and quite frustrating for providers. The national booking service and the local call and recall and the differentiation between them is something that we need to work on going forward to make sure there's a consistent offer for patients to get vaccine. And I think just the sheer size and scale of the programme can't be underestimated. Not only is it the biggest vaccination programme in NHS history, but it's already almost 7 times bigger than what we would do in an annual flu vaccination programme. And we've done that in just 7 months with, you know, the rest of phase 2 to go, phase 3 to come, and that flu vaccination programme that I've talked about. So we'll be well on the way to having delivered over 100 million doses of vaccine by the end of this year, I'm sure. Next slide, please. So just to finish on the next steps, we're working to that new target of having offered and hopefully administered everybody over the age of 18 with the first dose by the 19th of July, and as many people as possible to have 2 doses. We're continuing to bring forward all second doses to a minimum of 8 weeks now, and promoting the importance of that second dose uptake, as Liz emphasised before. The second dose really does provide the best level of protection, and it's really important that we do that, not just to reduce serious illness and death, but also to reduce opportunities for transmission. We really want to maximise uptake and cohort penetration across all of the JCVI groups, and that includes revisiting those who've previously refused. So that's that evergreen offer we've been talking about. And we're focused on increasing activity and promotion on the benefits of vaccination in our most deprived communities, so to tackle some of that inequity that we've seen emerging in younger people in our most deprived areas. As I say, that evergreen offer of vaccination will absolutely remain in place throughout the summer months, and anybody at any point is strongly encouraged to come forward and get a dose of vaccination. And with an eye on the future, we'll absolutely have to continue to collaborate and cooperate across all of our delivery models and all of those stakeholders that have been involved in the programme to complete phase 2, and also to prepare to deliver phase 3 in the autumn and the winter. So I'll leave it there and open up for any questions on the vaccination programme.
I've immediately got Jeff Watson, who's got a question.
I don't think anybody can doubt that we've been successful. We've had a really good time up in Northumberland. All agencies have worked well together. We've got the highest vaccination rate in the country, but we've suddenly had the highest infection rate almost in the country as well. And I don't quite figure out how that is. One says we're being very successful with a high rate of vaccinations, but then with the highest rates of infection. So anybody give me an answer on why that would be? And the second question I would have is, do we know yet how long these vaccinations actually work for? So there's two separate questions there.
So I'll take the first one. So in terms of the sort of high case rates, this is really being driven by young people, which includes those young people who haven't yet had the opportunity to have the vaccine, or to whom it's only been opened up in the last few weeks. And that's really the engine room of transmission. I'm not sure that we really know why some areas take off rather than others. You could say that maybe it took off in the northwest originally because they have had a number of areas that have had high rates for a long period of time. They do have some of the most deprived communities in the country. We're next door to the northeast. Perhaps there's been some sort of transmission between the northwest and the northeast. I think it's really difficult to understand, but what we do know is that actually where it starts off in one area, generally it does spread at a rate of knots to other areas of the country. But it's difficult to understand why our rates have taken off in the way that they have at this particular time.
Just in terms of your second question on how long the vaccines last, I think that's still one of the unknowns that we've got in this process. And because this is a new disease and these are very new drugs and new vaccines, that data is emerging all of the time. So the immunogenicity data that we've got at the minute is suggesting that a booster programme is going to be likely and necessary this winter for increasing protection to those most vulnerable in our society. And I think it's probably a fair assumption to make that we'll be looking at some sort of combined flu and COVID shot on an annual basis going forward to make sure that we top up our levels of protection against COVID and any new variants of that might emerge.
Thank you, Jeff. Yes.
Thank you, Chair. For us as a board, COVID is very, very important, but I also want to emphasise, I think our job over the next year is very much about health and well-being of everything else. And one of the things I just wanted to talk about here was about the scanning for extra inequalities that have come out through this in our populations. And also, I'm sure you're feeling it with your residents, the amount of demand and pressure in the health and care system at the moment, on top of doing this. So just to give you a couple of examples, in A&E, we're seeing type 1s, which are the very acute, very high levels, so they're in the right place. We've already got winter levels of demand in our hospitals and in our use of ambulances and services. And also, for example, with children, we're already seeing respiratory infections that you normally see in winter. So I think as a board, we need to be really looking at all of that as well. And just to give you some examples of it, one GP practice on a Monday morning get 2,000 calls on a Monday morning, and our primary care at the minute are seeing over contacts of 120,000 a month, which is much sort of 10% higher than it's ever been. So we've got to really keep our eye on this. We've also really got to keep our eye on making sure people get the care that they need. And it's a really delicate balance. And I'm sure you'll be getting comments from your residents as well about demands and pressures and access. So I think between us, we need to work really hard and support each other. And just to let you know that certainly from a health and care perspective, perspective. We had a board meeting yesterday of our System Transformation Board, and we are all working together to try and manage flow and overflow wherever it presents, so that our communities don't suffer alongside everything that's happening with COVID. Thank you, Chair.
I think on that, I'll go to the gentleman here.
Thank you. A tremendous presentation on the vaccination programme, and I would imagine everybody, and there are many, many people involved in that, they're all to be commended for the incredible work they've done to keep people safe and well and healthy in Northumberland. But a question for Liz, if I may. Liz, you mentioned about the communication programme, emphasising social distancing, hand washing, all the usual things. But bearing in mind the fairly radical change in policy from legislation to more personal responsibility, will you be gearing your communication programme to emphasise that change of emphasis, that there's more personal responsibility expected now, and how individuals can exercise that responsibility to continue to keep people safe?
Yeah, so I think obviously we will need to change our approach, because a lot of that is no longer mandated. As you say, it is going to be guidance. But I think I think our approach will still be to encourage people to certainly to adopt those behaviours which it's easy for them to adopt. So the hand washing, keeping windows open, good respiratory hygiene, the whole catch it, bin it, kill it, that, all of that works. But also encouraging people to continue to wear face coverings in those situations where we think it's going to be of most benefit. But I think it is going to be a challenge to get that message across. I think, having said that, I think there is still a significant proportion of the population who still want to proceed with caution, and will probably continue to do all of those things that we've been asking them to do over the last 15 months. I think, we're optimistic, but we still need to be cautious. I think that's the message.
Thank you. If I could follow up on a more precise one, Liz, if I may. A lot of people in the county, including the county council, in meetings such as this, would be wondering, do we maintain Zoom and team meetings in the interest of safety, or can we now move more readily into face-to-face meetings, bearing in mind the need for ventilation, distancing and so on? Will you be giving any advice on that, or will you expect organisations to exercise their own responsibility in how they move forward?
I'm anticipating that there will be some guidance coming out from the government, or certainly more detail than what we've had to date, and we're expecting that before the 19th, assuming we do still go ahead on the 19th. So from, in terms of advice, we would advise that organisations follow whatever guidance comes out from the government. I think, as an organisation ourselves, we would probably wish to continue to take quite a cautious approach. I think when the regulations changed to allow face-to-face meetings, or perhaps to not allow virtual meetings, I think a lot of local authorities were a bit taken aback at the fact that we would have to go ahead with face-to-face meetings, and there was a judicial review of that decision, but unfortunately, the decision was taken that we would all have to continue with face-to-face meetings because of that regulatory change. Clearly some of those meetings do have to be face-to-face because we can't continue to do them remotely. But I think personally, I think just continue to exercise caution, because case rates are incredibly high. And, we are seeing case rates increase through the age bands, albeit that they are lower in people over the age of 60, but that risk is still there, and I think we need to take whatever steps are necessary to avoid them.
Wendy Patterson.
Thank you, Chair. It's more of a statement, really, rather than a question. But I wanted to thank Stephen. That was incredibly interesting, that presentation. And as we move forward to July the 19th and to what we might term normality, it goes without saying that our NHS, our care workers, our medical services, and also our small communities who have seen us through. And it was really something the leader said about when we look back and take stock at how we managed over this period. I really just wanted to say a big thank you to our Director of Public Health, Elizabeth Morgan, because her calm and measured tones right through this pandemic has been absolutely wonderful, and she's kept us all going. And I just wanted to say a proper thank you to her. Thank you.
Yes, I think that's something we'd all second. I've just got a question myself as well, actually. It's to do with, and the leader mentioned about working with our neighbouring authorities, and probably after the 19th of July, I think that's going to be fairly crucial. We're all going to have lots more excuses to go to Newcastle or go to North Tyneside. There's going to be a whole new tranche of freshers students arriving, no doubt. There's going to be 52,000 fans at St James's Park, 10,000 fans at Kingston Park for the rugby, all sorts, and they're regionally supported teams, and we're going to need to work together. My concern is about, when I looked on the figures on the websites, how few vaccines there's been in Arthur's Hill, Fenham, Jesmond, places like that, which some respect will be down to the age profile of the areas. But I don't expect that's the entire story there. I suspect there's issues to do with us knowing who actually live in those areas, because people are more likely to be on 12-month rents and fairly more transient population. I know you touched on it in terms of going into the West End as well. How prepared are we for those challenges of the next few weeks, and how prepared are we to get the numbers which look particularly poor at the moment in those areas up?
So I think the System Vaccination Operations Centre that I've talked about are absolutely all over this, and is the highest priority at the minute in terms of diverting vaccine supply to those areas that need it most, and really targeting a lot of resources at those areas. So I think there's going to be 4 different roving models in operation in Newcastle next week and the week after, to try and maximise the opportunities that we've got for people to get vaccinated, particularly in those areas that you've mentioned where uptake is lower. So we're absolutely kind of throwing everything we've got at it in terms of supply. I think ultimately it will come down to personal choice and how people choose to be vaccinated. But I'd like to think the work that we're doing, particularly in our integrated care partnership area north of the Tyne, we've got really strong links, and we're working really collaboratively, and that'll stand us in hopefully really good stead to increase those rates. I think students will be interesting. We're obviously seeing a lot of students who live in Northumberland coming back from where they've studied to get vaccinated, and hopefully those that are studying in Newcastle who've gone home will get vaccinated there over the summer as well, and we'll be able to keep case rates down from that regard as well.
Yeah, thank you for that. I've just got a quick supplementary about the 12-week period and national booking. I've just moved my second one forward to next Friday evening. It's 8 weeks and a day. I didn't find that particularly easy. I'm probably in a lucky position that I'm in all sorts of meetings like this and know about it. I don't expect many of my peers the same age as me do know about it, or are moving their appointments forward, or whether they should be moving their appointments forward and things like that. What is the advice on that? Should people be going on and moving forward, or should they be staying at 12 weeks? What's the view on that?
The advice is absolutely to go on and bring them forward. You're absolutely right that it's not the easiest process in the world. The national team admitted when we first moved from 12 weeks down to 8 that the national booking service had never been designed to enable that functionality for people to reschedule appointments. So there's been a huge amount of development work done in the background on that service to make it easier for people to book at 8 weeks. Initially, you couldn't see where appointments were before you cancelled your 12-week one. Yeah, and that's something they're absolutely working on to make sure there is visibility of where appointments are, so people have got confidence that if they do cancel, they will be able to get one elsewhere. So yeah, we would absolutely encourage people who received their first dose via one of those national booking service sites to go on to the website, cancel their existing appointment and rebook. Likewise, people who received their vaccine in primary care are being contacted by primary care to come forward and get their dose at 8 weeks instead of 12, and supplies are being adjusted nationally to make sure we're in a position to be able to offer to everybody at 8 weeks. In terms of how we communicate that with patients, there are a number of FAQs that have been published that we've got on the CCG website and that we've shared with local authority colleagues as well, and we'll just continue to push those messages out via all of our social media channels, briefings that Liz does, briefings that we do for primary care and local councillors. So I think your support in pushing those messages out in your constituencies would be really very much appreciated.
Thank you very much for that. Have we got any more questions? Have I missed anyone? No, I think we're all done there. So thank you very much for that. I think we've got item 7, which is communication and engagement. Have we?
Sorry, that was those 3 slides at the end of
that's
it.
been
Yeah.
put in. Fantastic. So we're further forward than I thought. So number 8 is the health and wellbeing forward plan to note and discuss, page 85 to 90. If we can note that. Yes, Siobhan.
Thank you, Chair. I just wondered, given that quite a few of us are new to this board, about whether we need to think about some kind of development session and maybe a refresh around the health and wellbeing strategy when the timing is right.
I would be inclined to agree with that. I'm very new to this. This is my first meeting and I'm sat in the chair. We've had a bit of churn. I would agree that's probably a good idea. Absolutely. And I'm sure we can look to do that. Yeah.
Thank you. Just in that context, Siobhan, as we all know, the integrated care system and the emphasis on place as part of your presentation next time, will that cover how place will fit into the integrated care system and all the complexities but benefits of that liaison?
Yes, it will, with the proviso of, some certainty at a national level. But yes,
Okay.
everything we can share, we will.
Thank you.
Thank you. Yep. Yeah.
And again, if I may, I notice on the agenda something about terms of reference. Are we going to raise any issues connected with the terms of reference for this particular group, or?
Does anyone have any issues to raise on that?
It's the copy which, the terms of reference which were agreed, I think, a couple of years ago, and the new ones which came out with these papers, there's a difference in the development and improvement functions. And if I could just quote them, the one from a couple of years ago mentioned having regular reviews of the board's activity to ensure it is achieving what it is setting out to do, and also to provide an annual report to the Health and Wellbeing OSC on the achievement of the JHWS. I don't see those 2 particular items in the most recent terms of reference. So I'm just wondering if there's a reason for that, and who will actually monitor the effectiveness of this particular board. If I may ask that question, I hope it's not out of order.
No, I don't think any of us will pretend to have encyclopedic knowledge of the terms of reference. We just tend to see them at the start of every session we have. But Jeff, you have your hand up.
I don't know whether I misunderstood what you said there, but on item 16, isn't that one of the things that you said we didn't have? An annual report to the Health and Wellbeing Overview and Scrutiny Committee, that's there on the reference? 16?
Yeah, is it because it's on the next page? You missed it.
15.
16.
16. Well, mine only goes up to 15.
Oh, okay. I think we might need to check we've got the right papers or the right
Well,
upstate comment. Because we've got 15 and 16 on the next page. I can see why they'd both be missed. But
Well, I've got 14 and 15, but I don't have 16. It looks like I'm now going to get 16. Ah. I now have 16, yes, which I didn't before.
okay, is that sorted the issue you was raising?
One of them.
One of them.
Yeah. The other one was regular reviews of the board's activity to ensure that it is achieving what it is setting out to do, which seems a reasonable thing for any board to do, which was number 1 on the original development and improvement functions.
Yes.
So, I mean, I think you make a really good point, actually. I think the work of the board, I think, has been derailed a little bit by the pandemic. But at some point, we do need to return to, some level of normal working. And I guess that is partially dictated by the capacity of the people who support the board. But I think Siobhan brought up the issue of development sessions, and that was always something that we were keen to introduce. So to have development sessions interspersed between the regular board meetings, but that's tricky when the board also has this responsibility around the assurance of the outbreak control plan and how that's delivered. So I guess we just need to think about how we disentangle those issues. But I do completely take your point. I completely agree with you.
Yeah.
Thank you. Now that I've seen number 16 there, then the question has been answered. Thank you.
Well, I have to salute your diligence at looking at terms of reference, because we get them at the start of all of our meetings, and most people just nod them through without even noticing if there's any changes or what have we. So, yes.
It's just a small point. I think since the terms of reference is done, CNTW is now in place instead of NTW. And if you'd like to replace Russell Patton by me for the CNTW priorities, just for the work as well, the ongoing work going forward.
Sorry, I didn't quite get that.
So on the terms of reference and in the priorities for going forward and what we'll do the work plan, it's referenced as NTW instead of CNTW. So it's just that the name has changed since the terms of reference was done. And we have on page 87, Russell Patton is down for the NTW priorities, and I'll take that over for the CNTW priorities.
Thank you. Yeah, and just one other point. I have been saying yes, sir, and this I haven't quite got everyone's name yet, but I'm sure that will come in time. So thank you for bearing with me in that this afternoon. I move to the next item, which is urgent business. I have no urgent business. Date of the next meetings, we've got a whole list of them there, and the next one is on the 9th of September 2021, and I thank you all for coming this morning. Thank you very much now.